Assalamu alaikum. We'll talk today about the melanoma. Melanoma with you, Dr. Amer Musad, lecturer of surgical oncology. We'll talk today about melanoma, the type of malignant tumor, have specific biological behavior. Okay, it is arise from melanocyte in skin or mucous membrane. It is highly related to immunity. It is immunogenic tumor. It is affected by immunity. It is in general common in middle and young age, not old, not young. Let's talk about risk factor. Risk factor, simply there is agent, causative agent, is usually related to sun, and host. Agent is the sun, especially ultraviolet rays. It's the cumulative effect. Exposure to sun lead to repetitive severe sunburn, especially when it's beginning from childhood. The host has either immunosuppressed, as we said, it is immunogenic tumor or related to immunity, or has a defect in melanin production in general, as fair skin or blue eyes. Okay, the host either immunosuppressed or has defect in melanin production in fair skin and blue eyes. It's also related to past history of melanoma, family history of melanoma, or increasing number of moles in our patient. Host either immunosuppressed or has defect in melanin production, past history, family history of melanoma, or has a multiple mole. Okay, what is the precancerous lesion? Precancerous lesion is a giant congenital nevus. Sorry. High risk to turn malignancy. Atypical mole and melanoma syndrome. It is we will take about, and xeroderma pigmentosa. Okay. Yes. Let's talk about atypical mole and melanoma syndrome. It is familial disease. It is hereditary. It is autosomal dominant. Our patient suffering from multiple numbers of moles in early adulthood, more than 50. It appears in all over the body, especially in double covered skin, as breast, buttocks, and so on. It has multiple atypical mole, as we will discuss before. Yes, this is our patient. Yes. What is the atypical mole? Let's differentiate between typical and atypical mole. Typical mole, it is small, less than 6 millimeter, rounded, regular shape, even color or unique color. Atypical mole is the vice versa, large, notched or regular border. It is variegated color or fried egg pattern. How to treat? Let's remember how to treat atypical mole. Atypical mole is treated by excision if it is suspicious, 2 centimeter. If it is not suspicious, 2 millimeter. 2 centimeter, especially if there is abundant skin in the trunk and our upper limb, lower limb, you can excise with 2 centimeter margin. Yes, we can submit this criteria who differentiate between typical and atypical mole in ABCDE rules. A, asymmetry. B, border irregularity. C, color variegation. D, diameter more than 6 millimeter. E, elevation above. ABCD. This criteria is when it is present, it is suspected or atypical mole, it is treated by excision. To see? Yes. Here also asymmetry and the border and the color and diameter and elevation. To remember, all moles can proceed to malignant melanoma except simple type and lentigo type, freckles type. All other types, compound and junctional and blue nevus and congenital, all Hutchinson freckles, all these types can develop into malignant melanoma. Okay, especially congenital and blue nevus. Okay, let's to continue into morphological types of cutaneous melanoma. It is depend on pattern and site of melanoma. Pattern of growth, either horizontal or vertical. Horizontal, usually if melanoma grow horizontal more than vertical, it is gives for more favorable prognosis. If it is vertical more than horizontal, it is carries worst prognosis and rapid infiltration. This types is superficial spreading, nodular melanoma, acral melanoma, lentigo maligni melanoma, which is favorable, as we said, according to pattern of growth. Especially here, nodular and acral, there is vertical growth, superficial spreading, and the lentigo maligni melanoma, it is horizontal growth. So superficial spreading melanoma and lentigo maligni is more favorable. In general, lentigo maligni melanoma is most favorable. This is superficial spreading, nodular lentigo maligni melanoma, and acral lentigus melanoma. Superficial spreading, the most common, more than 17 patient, common in trunk or legs, especially in women. Manifestation, it is horizontal growth. It is usually flat lesion or slightly elevation, variegated pigmentation. Okay, more than 6 millimeter with slow growth pattern. Okay, and also it's irregular asymmetric border. This is criteria of 6 millimeter and irregular border. It's criteria of atypical mole. Yes. CC, this is variegated color, irregular border, large, and superficial spreading. This superficial spreading. Yes, superficial spreading. Superficial spreading. Okay. Nodular melanoma, second common, occur about 15 to 30 patient. Common also on leg and trunk. It is on vice versa, has vertical growth and rapid growth pattern. Superficial spreading goes slow, horizontal growth. So it is responsible for thick melanoma. This is more thick and more dark. More thick appears as a macule or babule or nodule, large. It is with rapid growth pattern, rapid infiltration, rapid vertical growth, worse prognosis, usual ulcerate and bleeding with minor trauma. Again, nodular melanoma less common also on trunk and legs, have a rapid vertical growth and responsible for thick melanoma and more dark melanoma. This is nodular melanoma. This is nodular melanoma. This is nodular melanoma. This is nodular melanoma. Okay. Okay. This is elevated lesion, thick lesion, darker lesion. Okay. Lentigo melanoma, third most common, about 4 to 15 cutaneous melanoma, usually occurring on head and neck and arms, usually in fair skin, has previous history of all the lentigo melanoma on the lentigo lesion. This is have slow growth, horizontal growth. This is usually appear as large patch or macule with variegated color and central nodular lesion. Usually our patient is old. This has a long previous history of benign mole called lentigo or Hutchinson flex melanoma. Which is, you see, it is a flat variegated color lesion with bust in the usual in old في الhead and arm And the neck, yes, this is lentigo melanoma. Yes, it's lentigo melanoma. Yes, this is typical of center nodular lesion, and all the patient, more in head and neck and arm, past history of pigmented lesion. This is all lentigo lesion. It is slow growth pattern, more horizontal, variegated color. It is flat lesion, macule or patch is central nodule. This is typical. Yes. Usually appears as irregular pigmented lesion, usually large lesion, more in plantar location in soul more than body. When you see this lesion, you should, without past history of infection or hematoma, you should proceed fast as possible as for patient. This is acral lentigomelanoma. Acral lentigomelanoma. This is acral number ABCD. Yes. Investigation for melanoma. First, we want to diagnose, usually by biopsy. Put either bunch, incision, oxygen according to size. If it is small, go to oxygen. If it is small or large, proceed for wedge biopsy or incision biopsy. The aim of biopsy to comment on the thickness and tumor extension into skin layer. So you should take full thickness biopsy. Not to forget full thickness skin biopsy. If you want to confirm by immunohistochemistry, you can proceed S100, HMB for 45, and melan A. All this is immunostains for melanoma. After we diagnose, we should go assess the resectability with the tumor, if it is resectable or not. It is resectability by X-ray, CT, MRI according to site. For staging, as usual, chest X-ray, ultrasound, brain CT, maybe CT, abdomen, chest, and pelvis is better. Not to forget LDH. Elevated LDH have a bad prognosis. Elevation of LDH with distant mets, it is considered M1C. You can proceed for PET CT, especially to detect in distant mets. For fitness, either as ECG and echo, CBC, INR, liver and renal function test. Says yes, yeah. Says what I see, what I mean with full thickness biopsy. Here, this is skin, epidermis, dermis, and subcutaneous tissue. Okay, excision with 2 millimeter if you suspect. 2 millimeter. Okay, if you highly suspicious and ulcerated in lesion and typical mode, you can, with especially in reluctant skin areas as trunk and so on, you can proceed with excision with 1 to 2 centimeter biopsy. You can differentiate from another pigmented skin lesion, which originate from, according to origin, from melanoma, benign mole or malignant mole, melanoma, basal cell seborrheic keratosis, basal cell carcinoma, squamous cell carcinoma, villoma, Bound disease, squamous cell carcinoma, hemangioma, and vascular tumor, syndromes of skin cancer, or pigmentation of endocrine disease as Cushing and Busch-Jaeger syndrome, and so on. Yes, let's proceed for management. Management according to staging. Stage 1 is thin localized. You can proceed. There is no lymph node and thickness less than 1 millimeter. You can proceed for wider local excision with 1 centimeter safety margin. If it is stage 2, when the thickness between 1 and 4 millimeter, okay, there is stage 2, T2 or 3 in 0. You can treat with wider local excision with 2 centimeter safety margin. You can proceed for sentinel lymph node biopsy if it is available. Sentinel lymph node is first lymph node drains the tumor. You inject either radioisotopic material around the tumor or patent blue or methylene blue around the tumor, and you check for regional lymph node, and the first lymph node which drain the tumor can be stained. If you detect, send for frozen. If it's positive, proceed for lymph node dissection. If it is negative, you shouldn't proceed for lymph node dissection. If it is not available, you can proceed either for radiotherapy or for elective lymph node dissection. Okay, if it is not available. Stage 3, what is infiltration more than 4 millimeter thickness of the tumor, you can be treated with wider local excision with 3 centimeter with lymph node dissection. Okay, lymph node dissection, even if it is negative lymph node. Okay, if there is in transit mets or satellite nodule, you can use regional limb chemotherapy or systemic chemotherapy and immunotherapy, target therapy. Stage 4 can be treated with immunotherapy and chemotherapy. Systemic disease is already metastatic, no value of resection, just for systemic therapy. What is the role of radiotherapy? Radiotherapy in general used for lymph node. If it is positive lymph node, either after lymph node dissection. If it is negative, can be used in T1 from the region thickness 1 to 4 millimeter, T2 and 3 in 0. Here, instead of sentinel lymph node biopsy or elective node dissection, stage 3, what is negative lymph node and tumor thickness T2 or T3 from 1 to 5 millimeter. Less than this, if thickness less than 1 millimeter, you shouldn't proceed for any lymph node dissection. If there is 4 lymph node, more than 4, you should proceed for surgery with lymph node dissection. Other melanoma of eye inoculation, it's a finger or digit amputation if the muscle infiltrated, removed from origin to insertion. If it's abdominal anal canal, usually abdominal dissection. If melanoma of lip and tongue and palate, treated by either local excision and local dissection. Thank you.